Well, good afternoon, everyone. We are going to get started. The APIC's Great Lakes chapter is pleased to welcome you back for another education webinar. Thanks for making the time to join us today. My name is Chao Win, and I'm joined today by my colleagues Kelsey Ostergren and Denise Parr. We are the education team for APIC Great Lakes, and I've had the pleasure of collaborating with Kristen VanderElzen to put on today's event. Our session today is titled Construction ICRA and New Building Planning, Notes from Infection Prevention. So just a few housekeeping announcements before we begin. If you can mute your line to minimize background noise, that would be great. And then drop any questions you have during the conversation in the chat, and we will circle back to them at the end of the presentation. Today's presentation will be recorded and slides will be made available. CE is not provided for this webinar. And with that, I'm pleased to introduce today's speaker, Kristen VanderElzen. So Kristen is an infection preventionist and epidemiology project manager at the University of Michigan Health. She has worked in infection prevention field for 30 years. Kristen specializes in construction and renovation, facilities planning, and device reprocessing. Welcome, Kristen, and I'm going to hand the floor over to you.
Hi, everyone. Really nice to be here today. I'm just going to pull up my slides and put them in presentation mode. Okay, can you all see that okay? Okay, I'll hear from Chow.
Yes, we can.
Okay, good. I'm gonna minimize my picture so I won't see you. So speak up if there's anything that goes wrong as we go through this, but it's really nice to be here today. And I'm really excited about this topic. I've given this presentation in different iterations at a few different places, but I would say most recently I did actually a collaboration presentation with National APIC on this, and I actually presented some of these things with one of my partners, an architect who's really one of the leads for University of Michigan Health on the new building project of the building I have pictured here, which is it is called the D. Dan and Betty Kahn Pavilion. And I'll talk a little bit more about that in just a second. But yes, I've been doing this a long time. And in our department, I actually kind of cover construction and renovation for overall the department. However, each of our individual infection preventionists do handle their own construction projects in their own areas. So I work a lot on the policies and on the bigger kind of overarching planning for these things. And so that's where I'm coming to you from. So just a little idea of what we have going on at U of M. Here's a picture of our medical center. We have over 1,000 beds, 72 licensed ORs right at the moment, but the pavilion, which is the kind of the new building that I'm focusing this discussion on, and it's kind of the backdrop for why I'm giving this presentation, is going to be opening at the end of this year. It's a lot of square feet, 12 floors. Its focus is neuroscience and cardiovascular. It's going to add 264 beds, inpatient beds. And even more significantly, I would say, is 20 licensed ORs. So it's really adding a lot to our OR grouping. So it's very surgery focused. So it's an exciting project. It's kind of unique. Some of the topics today, I'm going to really talk about how collaboration can help with infection prevention and who we want to talk to, who we want to build buy-in with, and explain why we can help each other out to prevent errors and things from happening in the long run. And it's been a big help over time. It's not an instantaneous thing usually. You do have to work at it. And I know many of you out there in infection prevention have been frustrated trying to get the attention of the right people to get your input inserted into the project when it needs to be. And it's something you just have to keep working at, but it does really help to kind of show your own value and how you can help in the long range planning. So we're going to try to talk through that. So, building relationships. One of the biggest things that I wanted to is really that I wanted to talk about is how you can do that. Oops, just lost my. Okay, for a minute there, I had Zoom on my screen instead of my presentation. So, one of the biggest things we can work on is making sure people know why and how we are important in this project planning business. So, why does it matter, and how our infection prevention focused engineering design can help patient safety, and how it can save money and energy? Especially, I would say, especially the angle on that, because sometimes, as you all know, infection prevention can seem and maybe does sometimes cost a little more to think ahead for patient safety. But one of the things I think we can really work towards is building for the long run. As you know, reconstruction is a big time waste, energy sink. It's lots and lots of money and lots of downtime. Nobody likes downtime in an active healthcare institution. You want to keep working. You need to keep taking care of patients. So preventing reconstruction and making sure things will last is really helpful in the long run. So this is just kind of a graph that's showing you how infection prevention planning can kind of reduce the long range need for retrofitting, is how they put it, and improve safety. So the construction and design planning, as you work later into the design and you add things late in the design, as you probably all have figured out if you're involved in a construction project and you say at the last minute, oh, that's the wrong spot for that hand washing sink, you get a lot of grief back at you. And there's a reason for that because you're already far down the planning process. There may be drawings, there may be bids from contractors that are already in place, and changing things can add a lot of time and money. So getting in at the early stages is really key. And I'm going to talk a little bit about how we try to ensure that. It is not perfect, but, and I actually have to keep educating the groups that need to know this continuously. I actually gave two presentations to different groups within our institution this year, and I feel like I need to do another because we already had a gap happen where we did not get contacted early enough. So it's an ongoing thing, but you have to stay on it and try to not lose your patience with it, but keep going. So some of the things that, we want to talk about, maybe anything from as simple as where do you put your hand sanitizers to something as extreme as what's your water management system and where does it go and how is it treated and how is it tested, and all like really intense plumbing or intense air handling questions. And you can get into the weeds, and these weeds can be really good if you know what to tell people. You don't have to understand engineering and plumbing and how to read really intricate drawings to be able to advise people. So as long as you can write out what you're asking for in words and be able to like get them to the point you're making, you don't have to be able to do all the planning for them. It's the architect's and engineer's job to interpret what you're asking for and put it into the drawings. So all of these things are really important, making sure the cleanability of your surfaces are good and that they're going to be able to withstand frequent disinfection. And then there's lots of water related things. That's kind of one of my favorite slash main topics that I deal with is water in all kinds of forms, how we manage it in the plumbing system, how we manage it in dialysis, water treatment in CSPD, and in other areas where there's water treatment. Those are kind of like things that I'm especially into. And our department led the water management team at University of Michigan for many years, and we kind of still do. My colleague who's an environmental health specialist, is now running the meetings. But it took a long time to get buy-in in that, but that actually was very relevant to our construction design and all of those things. So yeah, and there's lots of other things that we want to talk about. One of the things, and I know not every place has this opportunity, but one of the things that we really want to have at our fingertips is design guidelines. This has saved us from rework and redesign so many times I don't even know. But it's been really lucky that we've been able to work with our facilities operations and planning department to create design guidelines. And I'm going to go through a few of these. I know not everyone has access to something like this, but what you can do from an infection prevention standpoint is create your own kind of hot topics, things that you know you want the architects and engineers to notice and to look for and to make sure. It's not really just reiterating the building codes because they are supposed to know these things. It's highlighting the things and maybe giving some nuance to the building codes. And maybe there's stuff that goes above and beyond the building codes that is especially important for your areas. So our facilities engineering and planning department has several design guidelines that have really helped. There's a bunch related to mechanicals like ventilation and things like that. They're not necessarily all specific to the healthcare system, but we do have a section that is specific. It's called special building areas, but then there's all these technical requirements that are like the plumbing design and things like that. So they're down there, and there's details with like down to the level of the size of the faucets and where they discharge and things like that. So there's a lot of work that's gone in over the years, and thankfully I did not have to write any of those, but I did give a lot of input to some of them. So yeah, we'll talk more about that. So here's an example of one of our architectural woodwork. I would not have guessed that I would need to weigh in on this, but we actually really did because it's where we talk about our hand washing sink requirements. And so some of these designs here were built before we actually had as much information in this document. So the picture on the top left and the top right, those are actually images that, I just make sure that you can see it, images that were designed according to our architectural woodwork supplemental plumbing specialties design guideline. One of the main things that I'm really proud of is any place where there is a countertop that staff are planning to put clean items, we have required a splash guard. They're somewhat different sizes, but you'll see in the top right one, they had told us that they weren't planning on putting things on the countertop. So there wasn't one there, and that was probably had to be added afterwards. It's, I think, better to incorporate them into the design, and it has really saved us and given the staff the opportunity to set up like clean work surfaces for doing different little procedures, minor procedures in the outpatient setting, and sometimes even setting up important things that they're getting together for patient care in the inpatient setting. So we have all these lists of things. We want non-splash design, offset grid strainer so that the water faucet discharge is not directly over the drain. That is one of my favorite topics, and I'll talk a little more about that, but maybe we'll talk a little more in the questions afterwards. A non-splash design, so thinking about how you can not splash out of the faucet without having an aerator at the end. And there are a bunch of different ways. We've had to learn this kind of through trial and error. But now there actually are some healthcare designed faucets that have the aerator, which kind of manages the flow control in the base of the spout. And there's some real benefits to that, I think. One is that it makes a smooth water stream, less splashing, but it doesn't have the thing right at the end of the faucet that has exposure to air. And the air exposure, I believe, does increase the risk of biofilm growth because there's so many organisms that are in water but want air and oxygen to grow. So here's another list of some of our things. One that we use a lot and that people have talk to me about a lot is our healthcare procedure room infection control types. We just revised this, and it's kind of a cheat sheet for infection prevention, but it helps us make sure we're designing the room for the procedures that are intended, and that can be really tricky. I'm working on another project right now where they're thinking about in an outpatient setting what kinds of procedures, what service lines, what doctors are going to be working there, which they may not know 2 years in advance. But we need to try to anticipate what are they going to be doing in this space, and so that we design the room to the right square footage, to the right ventilation, to the right materials and surfaces. So we have all of these things kind of segmented out in tables in this design guideline. And it has really helped our architects, especially the architects from outside of U of M, to be able to really understand what we're asking them to do. We also have critical pressure sensitive rooms, which is a newer one that our engineers worked on for ventilation, and that we gave a lot of input related to. And then we have like things like pharmaceutical compounding rooms. There's a lot of different things, but I just wanted to give you a sampling. So the infection control room types kind of helps decide things. These are two extreme views, like a C-arm, CT scan, and an OR. It designs and describes from both the infection prevention's perspective, but also from the engineer's perspective, what they need to be incorporated into the design to be able to meet our expectations of airflow, filtration, and where the air is coming in and where it's exhausted, and all of those things. So yeah, there's a lot that goes into that. And here's just a little example of some of the tables from that guideline. And it's never perfect, but we've tried to take the FGI 2018 building code standards and kind of modify them to meet our terminology and add to them. So that's kind of what we're talking about. It includes things like pressure, airflow, air exchanges. There's a whole bunch of detail in this guideline. We do have the pressure sensitive rooms, and it talks about things like monitors, the types of doors, where anti-rooms are required, and all of these things. So this, I mean, this kind of helps so that I don't even have to say these things. I just say, see this design guideline. And then my role or my colleague's role is to look at the design when the drawings are made and make sure nothing gets missed. And actually, that's a really big deal because things do get missed. Even when you have everything spelled out, you really want to make sure that the things that we care about didn't get missed. So here's some of the things that I will call out when I'm talking to people. And these are some of my favorite design features to talk about: space and clearance. And that's one that's hard to explain, but basically you want to think about how much things and equipment are going to be in the room to manage the people flow, to manage things like ensuring a sterile field can not be contaminated. All of those things can kind of help make sure that infection prevention is working. Surfaces, I know most of you are very familiar. We need surfaces that are cleanable. I wish that there was more testing done on some of the materials, but they change so quickly that the long-term testing is kind of tricky. So like making sure that something is durable is not so easy to do. You can make sure that it's not going to be discolored, at least in the short term, but how do you ensure that something is going to last for 15 or 20 or 30 years? That's really not done so much unless you have an existing thing that you really like in an older building. The air, we of course want to manage that in certain areas. We want to think about new technologies. How are we going to do special disinfection for certain organisms? We want to manage airborne isolation, things like that, triage areas. But a lot of that is pretty straightforward. Now, one thing that we have gotten into a lot more heavily is understanding the design of the actual air handler. And in a big hospital building, it's very different than in like an office building or a factory or something like that. It could be similar, but generally they're pretty different. And the design of the air handler is actually really important in where the different things are in relation to it, specifically where the humidification and where the final filtration racks are. And that's something that we've found that we did not have consistent across all of our buildings, partially because we were not paying attention to it and we weren't calling it out, but also we just didn't know to do that for, 10 years, 15 years ago. Water, of course, has made a lot of headlines in the last 20 years, but especially probably even more recently. So definitely water is important. We used to think it was mostly about hand washing access, but I actually think it's so much more complicated than that now. The drain question is a big one, and I have a couple images of that where we'll talk more. But there's definitely new technologies for water active disinfection. I don't know a ton about them, but they're out there, and it'd be really nice to see more studies on them. But one of the things that we've really worked on with our central sterile processing areas is the water treatment that goes into our equipment. And it has taken a lot of time and a lot of investigation to figure out some of these things. And I will say that myself and some of my colleagues actually, I think, understand it better than almost anyone in our whole institution because we've taken it upon ourselves because we've decided it's actually a pretty significant risk from an infection prevention standpoint. So reprocessing and storage areas for sterile items and other items is a really big deal. Um, we could get into that for hours, but we'll keep moving. So this is a picture that I like of a patient room, a new design patient room. And I tried to circle some of the features that I thought were really important for this room. And the yellow ones are the surfaces, and the red circles are items that I care about. So it's a little hard to see some of them. From the left to the right, the chair surface. It's really straightforward, but we have some new areas where the chairs can't handle the disinfection that we do, and they're already tearing within a couple years. So really thinking about, especially the seat and the arms, how those can stand up to disinfection, at least on a fairly frequent level, and the types of disinfectants that you have is a big deal because you don't want ripped things in your institution. Now, the top, I'm not saying this room is perfect. I actually don't like some of the features here, but some of them are good. So the left red circle is a flat dressing cabinet or like coat cabinet, and it's flat top. So who's going to be able to dust and clean up there? We know those attract dust. So anything high dusting, we want to have a sloped top. So that one is actually kind of an error. Thinking about the surface of the bedside stand. Well, that's pretty straightforward. Shouldn't it just be cleanable? Well, amazingly, we have stuff that is getting really damaged by different things that the patient treatments might have, like different chemicals, not just cleaning things, but stuff like that. So thinking about that surface and what is in your design, what is it, who's deciding what to order there? Get yourself involved in that and talk to them about durability and cleanability. And the same is true with the flooring. I know many of you have seen examples of flooring that can't withstand simple things like dripping hand sanitizer, or things like the disinfectants that your housekeeping service use. We have actually seen also buckling from pressure of the beds and the weight of the beds. And that has actually led to extensive reconstruction. So making sure the flooring can handle the weight and the kind of constant pressure in around the wheels of patient beds is important. Thinking about that. We could get involved in lots of stuff, but the sink, of course, is important, and the hand sanitizer are both circled in the middle of the picture. The sink, this design is not like anything we have, but I actually like it because you can see the countertops are standing height and they have their own built-in splash guard. Now, I would want to make sure that that sink height is appropriate because there are, of course, guidelines for that. But I do like the fact that the countertop has its automatic splash guard. It's at a higher level than the sink, and I think that's really interesting. Thinking about things like where there are countertops, where splash guards are located, where's your hand sanitizer? Is it convenient if it's is it convenient to the staff when they're working with the patient, and also upon entry to the room? Showers, I think don't get enough attention. In an inpatient setting, they may get a lot of use or they may get really seldom use. And there's two aspects of that. Water stagnancy has to be thought about, and especially those cords with the shower fixtures, if they're stagnant for weeks and then someone decides to take a shower, is that person getting safe water? I don't know. And I would be concerned about that. That's a tricky one to figure out. But there are special equipment now that can help out with that. Thinking about the tiling and how the shower curtains are made, I know most places now create zero entry showers. That's great for, a patient care setting. But the problem is the water goes everywhere if the shower head is not directed appropriately, and it can actually make a slip hazard, and it can pool outside if the patient's taking an especially vigorous shower. It can actually go outside and damage things that weren't intended to be water resistant, like your edges of your doors and things like that. So there's so much just in this picture. I should probably move on, but we'll talk about the faucets a little more. But I know you probably have heard this before, that water is a really big deal. Now, we spend a lot of time preventing surgical wound infections, surgical site infections, bloodstream infections, but how many of them actually originate in the water? And I think it depends on the patient population, but there's a lot of Pseudomonas infections that we don't know why they're there, well, where they exactly came from. And I think the water sources are a big, big concern. There have been huge outbreaks in especially Europe and in certain patient populations like neonatal intensive care units, where they've done huge construction projects because of outbreaks in those patient populations that were linked to the faucets and the plumbing and the drains. Sometimes all of those, sometimes just the drains, but usually it's like a vicious cycle. So, like if stuff is in your drain heavily contaminated, it's going to splash back up onto your faucet. And how much biofilm grows in that faucet is dependent on a lot of things, including the use of the faucet, the chlorination or the treatment levels, and all of those things. But there's some estimates that Pseudomonas represents up to 10% of HAIs, and I would not be surprised about that. This outbreak that I'm going to just kind of go over is one of the things that really sparked my interest in water and construction related to water systems. It was an outbreak in a pediatric ICU, and it was really sad. They had actually had a bunch of deaths. And this was from 2009, Hoda et alia. And I definitely suggest looking into this if you're involved in any plumbing design related to sinks and hand washing. They actually had this huge outbreak. They linked it to the sinks and the faucets and the drains. It was a little hard to tell what caused what, but they did identify that the drain contents, literally stuff in the drain, splashed at least a meter from the sink and could get onto various surfaces, onto people's bodies when they're washing. It could get onto, that's why splash guards to me are so important. And also why you have to think about aerators and things like that. They tried really hard to disinfect the drains, which is almost impossible. And finally, they renovated and with a completely different design where the faucet was offset from the drain, and it made a huge difference, and the outbreak was terminated. So that's one of my favorite examples of how design can really impact patient safety. So here's some pictures. I don't know if you guys have done a survey of your faucets, but I highly recommend it. These are all pictures that I have taken over the years. I will happily say that most, maybe all of these are actually not even possible in our institution anymore because we don't have these kind of faucets anymore. So yeah, shocking. But if you look in some, maybe you have older areas or older buildings, you're going to find all kinds of faucet types, including things that have external aerators or internal aerators. And then there's just plain scale related to the type of water that you're dealing with. Like some water is more prone to scale forming on the faucets than others. And yes, we did culture some of these, and yes, pathogens were in some of these. We were lucky enough to have some assistance from our trauma burn lab, who is separate from our micro lab and or from our main micro lab, and they were happy to investigate a bunch of things because they had concerns. And we found lots of interesting things, including Pseudomonas, Cenotrophomonas, Acinetobacter, and molds. So those are all important. The one on the left, I am actually not sure where that was, but I think it was a scrub sink in an interventional radiology area, which I don't know if I'm supposed to tell you all this stuff, but none of these are existent anymore. As soon as we saw these, we really hounded our plumbing people to exchange them to a completely different form. So faucets and aerators do not have aerators on the external side of your faucet. This is some information on electronic faucets. This is a little more controversial than just the straight up aerator question, but electronic faucets have had some implication to harbor biofilm in them and have a really difficult time clearing a particular organism. And especially, I would say, in Legionella investigations, I've heard of this being a real issue. So the picture on the left is a standard faucet. The picture in the middle is a electronic faucet. And you can see that it's almost impossible to get in there and think of all the different paths and all the little pieces that could get contaminated. Another part of the electronic faucet design that is problematic is that it often has its own mixing that always has temperate water. And from a Legionella perspective, because it's increasing the water temperature in that faucet, it puts it closer to the growth range of Legionella. So we actually do not allow electronic faucets, and they're just sometimes frustrating to get them to go on when you want. So from a healthcare worker perspective, when they want quick hand washing, they do not want to mess around with the electronic eye, and it sometimes works, sometimes doesn't. So we do allow those in our public areas, but not in any of our clinical areas. So I just wanted to give a little about that. Here's some images of splash guards, offset drains. I actually, the one on the right, you can't tell, but that one is actually nice because it's got a sloped angle in the back of it. But we have some newer designed solid surface sinks that we've used that actually slope the water away from the drain, and they're really fancy, and I like those a lot. I don't know for sure that they're doing what we want them to do, but I think they're better. So here's some examples. Left, nice splash guard. Yes, you have to keep your paper towel and soap on this side of the splash guard. I actually have seen some installations where they put the paper towel either halfway over the splash guard or on the other side. And of keeping track of those locations is important. But this is on the right, you can guess there's all kinds of patient supplies that could get contaminated. And we are definitely eliminating that whole kind of concept from any new design that we're doing. So one of the things I can really advise is to keep a list of things that you know you don't like in your existing facilities. Modify it, investigate it to find something that works better in your design, and then share it with your architects, engineers, and user groups. And if you have not everyone has their own internal interior design group. But if you don't, you're probably hiring people to do things like pick the shower curtains, pick the cubicle curtains, pick the flooring, pick the countertops. So share that with those people, with the architects, interior designers, and go over why it's important. If you don't have it in an official guideline, you may have to follow up with them multiple times. And that is something that I actually recommend doing anyway in any new construction project is kind of, especially a big one where lots of things are happening, keep a running list of things that you're concerned about. So, for example, in our ORs and procedure rooms, we keep this running list and I reiterate it for each new project where it's relevant. We want to keep people's kind of some of this stuff is in the building code, but I want them to like be thinking about it and have it in the forefront of their mind while they're designing it. We have special filtration, final filtration expectations that are above the building code minimum. So we want them to remember that and know that. And then thinking about operating rooms and procedure rooms, they need redundancy. And that's also in our design guidelines. So there's a bunch of miscellaneous things that could come into play. Thinking about where carpeting is allowed. We actually are really, really minimizing that. Pretty much it's only in office spaces now. But fabrics, furniture, flooring, countertops, all of those things, you can have like your own kind of minimum expectations for those. And actually, people might like it if you gave them ideas of things that work well and that have stood the test of time. You may have examples that you're like, yeah, that looks great, and it's 20 years old. Share that, use that, consider that. Of course, decorative fountains and pools, we really want to stay away from. Um, I suppose there's some methods where you could manage these, especially if it's all fully contained and managed by an outside company. But I will say the outside companies come and go, and the contracts come and go. And for example, like a fish tank, we have fish tanks in a few places. We have an outside company that takes care of them, but you may set up guidelines for when they can come in and do the cleaning and the draining and things like that. Uh, the next company that gets hired 5 years later may not know your expectations. And we actually had one come in during a busy time in the waiting room and start draining and cleaning the fish tank. And we were like, no, you can't do that. Yeah, things like that. I actually am I don't have a lot of data on this, but a big advocate of finding a way to manage cubicle curtains that does not require them to be fully taken down. There's lots of different things out there. You can see different things if you go to national APIC or conferences. I don't know which option is best, but the taking down of curtains, especially in outpatient procedural areas, is really not done. And I don't know, there is definitely some organisms on those. I think we should find a way to manage those that's better. I have my own thoughts, but I don't want to say that I know better because we don't have any proof yet, but I do think there are better ways. Shower curtains, not something that we would typically think about, but if you've ever been in a shower in a patient area where the curtain was dragging on the floor, how often does that look clean? And even in your home setting, if it's hanging out in the water all day, it's going to grow biofilm. And no matter how good your housekeeping is, that's something that can get missed. It could grow mold. It could grow serratia. Lots of things. So having it just the right height where it's not dragging or hitting the sides too much. But if it's too short or non-existent, I don't really like, unless the wall is built around it, I don't like no shower curtain because you really do need to manage that water. We've had experiences where things have rusted out because the water traveled 6 feet away and yeah, things like that. So, as I kind of mentioned, we keep kind of a running tally of our ICRA measures, and this is for design ICRA, not just for the building, although we in the same document might talk about earth moving and management of dust during that, or the management of connecting two buildings and what we want to happen when that happens. But we definitely keep a running list and a tally that we go over for our new pavilion. I've met with our leads from U of M that are the liaisons with the general contractor. I think we've met with them on specific infection prevention things probably 5 or 6 times over a few years, and we're not done yet. So we keep a running tally and keep checking in with them. And one of the best things that we caught. Would have been nice to catch sooner, but we literally got to go on site. And that sometimes is tricky. You have to have an escort usually, and you have to gear up and wear your hard hats and stuff like this. But we did go on site as they were just starting to complete some of the build out of our new inpatient tower. And we found that they had used the wrong faucets and they were discharging directly into the drain, and they had installed one small area already. And we're like, that's not right. Please check on that. Don't do any more like that. And they actually, it took them a little while to check on it. And when they did, they realized they had actually not designed it to specification, and they had to send like 1,000 faucets back to whoever they bought them from. They did it. They weren't thrilled about it, but they did it luckily before too many were installed. So, yeah, that was actually a really lucky thing that we caught together with our lead architect when we did a walkthrough. So, going on site and looking at what they're building as much as is feasible. And then thinking about things when you go during the construction phase, you can actually look at safety items like, are they protecting the clean ductwork? Is it have the covers on it so that there's not like all kinds of construction debris getting into it? Is the drywall installation appropriate? Are they leaving gaps at the bottom of the drywall so that it's not on the floor? I can't even tell you how many times that has saved us from having to remove a wall after a plumbing leak. You need a little bit of a gap. I think a little bigger is better, because you can't, it's so hard to remove drywall when you have an active patient care area. It's a mess. It's shutdown time, as you all know. So if you can protect that drywall from a little leak, like the toilet overflowing, simple things like that, that is a great thing. Checking the plumbing. So we actually also caught some plumbing anomalies in our new building, and also made sure that they were putting sampling ports where we wanted them to be able to sample the treated water, like our reverse osmosis distilled water or deionized water. We actually had to ask them, even though we had already put it in our guidelines, they did not have the sampling ports in all the places. So they had to install those, but they could do it while the construction's happening. If everything was finished and the surfaces and drywall and the paint was up and everything, we would have got a lot more pushback on that. We also did a lot of looking at the air handlers. That's not something that everyone knows what to look for. I've learned over the years, and also my colleague has really focused on that and learned a lot about air handlers. So he has gone and done a ton of inspections with those. We want to check all the finishes that they're creating. Do they have good seams? We actually got called into the new operating rooms where they have the cleanable walls, but they have the little, they're pieces of cleanable installed walls, and they have like a little seam cover. Well, the seam covers were all kind of bent and not flush with the wall. And luckily someone brought that to our attention and said, "Yeah, I think we probably need to make them redo this." And we were like, "Yeah, that's gonna grab dust. It looks bad." I mean, I think it's really reasonable to do things like that. You want your finishes to be flush and cleanable, and those would have probably not lasted very long. Then there's last little tidbits like, where did you put your hand sanitizer? Sometimes the as built is different than the design drawing because something isn't quite meshing. The electrical work is in a slightly different spot, and the hand sanitizer you pick 3 years after the design is bigger or smaller. And so thinking about those little things is really important. We've got this running list, and I just pull pieces out that are related to the project that we're working on. And then here's an example of the ongoing dialogue that we have with our current building that we're working on. Just looking at the drinking fountains and the filtration and the types that they're installing, the ice machines, the ventilation. We're checking a lot. We've done some pressure differential testing because we're at the phase right now where we can actually test some of that. They're going to do balancing and things still, but and this is not my favorite thing that we have to get involved in, but I don't know if any of you have ever had this experience, but the fire prevention laws and the amount of alcohol you can have in a fire compartment don't always mesh with what infection prevention thinks is good process or good um, amounts of alcohol hand sanitizer on site. So we actually have had to really physically go on site and say yes here, no here, yes there, but we can probably get by without it there. And then help make sure someone's doing the calculation for the total volume. That is not something I love doing, but we've helped with it. And it's important to think of before you open the building because the fire marshal might have some concerns. So this list is kind of like a running list and we update it as we meet with them. We also do things for smaller projects, and I think other places have kind of similar things, but this is a, a check beyond the ICRA. We call it our IICM, and basically it's almost like a as-built ICRA. So how once the contractor sees what they're expected to do for the project, we want them to tell us after they've understood the drawings, maybe been on site, seen what's actually there. We want them to tell us how they're going to do the construction barriers, how they're going to do the ventilation and negative pressure, and the plumbing, any plumbing needs that they have. And then we go through based on what they say and say, yep, that works, yep, that works, or no, I need more information, or you didn't tell me enough about this. And that is not a perfect process, but it has definitely saved us many, many times from inadequate barriers, from non-existent negative pressure when we needed to have negative pressure, and lots of other things that has really helped us. So this kind of double check of no, tell us really how you're going to do it. Not just say, I'm going to create negative pressure and use a construction barrier. Okay, show us where, show us how, and explain it. And we've actually had to redirect them lots of times based on our experiential knowledge of what works and what doesn't work. And we fill that out. So we asked them also for, oops, there's a weird thing there. You can ignore that, but there's a drawing, and so we asked them to give us kind of like their own drawing of where they're going to put the HEPA filters, where the actual doors are going to be, the temporary things, all of those things. And that has really helped, I think, the contractors be more efficient because they have to figure it out before they get on site and ready to start, because we need to give them back this checklist. So that has really helped us. And just in completion, get to know your players. Now, not every health system or hospital has construction project managers. U of M does, and they definitely change over time. So everyone, staff changes. So we've had to re-educate and continue to build that relationship. But we have also gotten to know a lot of construction companies and the leaders for those. Many of you probably know your leaders in your area and explain to them what you're after and show them how you can help them be more efficient by knowing exactly what they're getting into up front and to make sure you don't have to fix things at the last minute because it's wrong. And so, all of those things I think really save time and reconstruction money and time downtime from patient care. And I think that's the construction planning best way that we show our value in infection prevention is to help them understand what's going to save rework in the future. And that's kind of my final tip for everybody. Educate, and you're going to have to re-educate a lot. So keep going. And then I can open up to questions. There's an ample.
Thank you, Kristen. That was a fantastic presentation. We really appreciate you sharing your wisdom and your experience with us. For the attendees, I have a few questions to ask, but if you want to put your question in the chat, I can pull it over and ask it as we go through. First off, when you were going through the design guidelines slides in the beginning, a few people asked, do you know if you could share the room type documents that you were discussing there?
I get that asked that a lot, and I believe it is public access online. I will share it, and maybe someone can make sure they can from outside can access it. But yeah, it is, I believe, public access, but it's hard to find on our websites. So yeah, I can try that.
Excellent. If you provide us the link, we can actually put it on with the slides so that
Mhm.
way they have them
Mhm.
together.
Yeah, and we can just make sure it's accessible for people. So,
Thank you.
mhm.
Speaking of water, any position or incorporation of water-free ICU rooms in either your pavilion or in a future project?
We have not gone there. I think that is actually a really logical thing. I don't know how many people have experienced or have done research into the outbreaks in places. There are places, especially I think in the Netherlands, that have implemented that in some good studies with good results. I will say that they probably did it because there were such extreme problems in their plumbing systems that they had that they were willing to really think outside the box. I don't know if the United States is ready for that from a like concept, but I think it has some logic to it as long as you have access to some running water if people get, soil on their hands. I don't know of any place in the US that has tried it. There there could be some, but I have not heard of their results and what the staff thought. But I do think it probably is a very logical thing to consider. As far as I know, the building codes in the US don't allow for that yet. So we'd have to really work on the building codes first and probably have a few more studies.
Thank you. What are your thoughts on carpeting in hallways in ambulatory clinics? Not in the exam rooms, but in the hallways outside of the exam rooms.
I think it's much less concerning than in lots of other places. I actually don't like it in waiting rooms because people are sitting there and I suppose there's a lot more chance for accidents on the carpet, vomit, and everything else. But certainly we have experienced people vomiting on our carpeted hallways in some of our ambulatory sites, and I would recommend not doing it. Um, it's certainly a lower risk level than some other things that I can think of from a patient safety thing, because most of that cleaning is done when there's no patient care going on. So that's different than a 24-hour a day inpatient setting. Obviously, cleaning has to happen even when there's patient care happening. But in the outpatient setting, usually the housekeeping comes in at night and it's very different. I don't love carpeting, and over the years, you end up having to replace it because it doesn't last as long as some of the other hard flooring surfaces. And we actually just finished in our biggest, I think it's our biggest ambulatory setting that is about 25 or 30 years old, replacing all the carpet. And that was a big project. It took about 9 months to get it done because they were only doing it on the weekends. But I think it'll be good. It's just, picking the right flooring is tricky sometimes. It's hard to know what's going to last. But I don't love carpet. The vacuuming is concerning. I don't know. That's
Thank
my
you. How often do you perform construction rounds on an active project, and would you be willing to share a rounding tool?
Yep, we do have I think, a pretty good rounding tool. Um, we do from just the infection prevention group. We don't expect all of us to go in inside the construction zone every week, but we do really try to go at least weekly. If you have a big project in a high risk area, I would definitely want eyes on more often than every week. That can be hard to do, especially if there's a small IP contingent. Even with a lot of people, it's sometimes hard to do with all your other things. So you have to weigh it in the grand scheme of all the stuff you have to do. But we try weekly to go and check and make sure the barriers are tight, that they have their checklist posted and they're checking things. And we do the best we can to check negative pressure without going inside. We actually used to do construction rounding with our project manager, construction project manager team, and we were doing that between 1 and 2 week, every 2 weeks. Um, Definitely, when you can go in the site with someone who knows construction and knows the people, that adds a whole new dimension. That was kind of fell by the wayside with COVID, and then we have never really got it up to where it was before COVID. Um, but that was a real learning experience. And if you can do that every once in a while with someone on your construction team, you're going to learn a lot and know what to look for. And it's really informative and helps the project run smoother.
Again, thank you so much, Kristen. We
Mhm.
really appreciate you presenting today.
Absolutely.
So now we'll move on to the next slide, please. So our upcoming webinars for APIC Great Lakes is July 8th. We will be having the infection prevention collaboration between hospitals and nursing homes. August will be our member presentations. October 9th is our conference, and November 4th will be NHSN Rebaseline. Next slide, please. So please save the date. The conference will be October 9th. Our theme is Weathering the Storm, and we're very excited about our speakers and topics this year. We have Dr. Alexander Sundeman talking about whole genome sequencing. We have Aaron Woodall talking about infection prevention and dementia care. And then we have an ambulatory setting speaker talking about infection prevention. And then we're going to have another little presentation about kind of some things you don't normally think about with infection prevention, but it does pull you in if these items happen. And then finally, an investigation interactive session. So we're excited to be closing up our planning of this, and we hope to have registration open on June 2nd. So please watch your emails so you can get registered early. Next slide, please. If you've missed a webinar, no worries. After the ending of this webinar, we will be taking the recording and uploading it to our YouTube channel. So please go to our YouTube channel and like it and follow us so you can see when we put new materials up there. And then the presentation slides and supplemental materials will be shared on the APIC Great Lakes website. Next slide. If you have a job posting, please reach out to the APIC's Great Lakes Gmail to let us know that you are looking for some staff, and we are happy to put it to our board. And then we're also going to be able to shore that out with our LinkedIn page that we also now have, which is fantastic. Thanks to Rebecca. Next slide, please. Okay, thank you so much for joining today's webinar. We are going to now be stopping the recording, and we are going to switch over to our peer mentorship roundtable. And this session is going to be facilitated by Jennifer Gubler. You can take it away, Jenny.